I'll go ahead and get started. Thank you guys so much for coming and participating in our Pharmacy Section Journal Club for the month of March. We have two really great presenters today. Dr. Harrison Hamada, he's a current PGY2 critical care resident at New York Presbyterian Hospital. And then we'll follow that with Dr. Eric Kennison, who's a PGY2 critical care resident at Intermountain Medical Center. I will stop sharing and let you guys take over.
Hey, well, thank you for that introduction. Today we'll be talking a little bit about seizure prophylaxis, specifically early seizure prophylaxis in mild and moderate traumatic brain injury, which was a systematic review and meta-analysis, which actually came out last April. So just to jump into a brief background, the CDC estimates that traumatic brain injuries, or TBIs, actually account for nearly 2.5 million emergency department visits, hospitalizations, and deaths in the US annually. Now, a common complication that we often think of when we're thinking of the various kinds of TBIs are going to be post-traumatic seizures, or PTS. They've been found to lead to increased hospital lengths of stay, mortality rates, and worse overall functional outcomes. Now, while we just all agree that these are bad, the reported rates of early PTS typically range on the lower end. When we look at specifically mild to moderate TBIs in the literature, rates of seizures here actually range anywhere from 0 to 4% in that early window, so within 7 days of injury. Now, on the flip side of that, we also know that evidence suggests that at least or roughly a quarter of TBI patients are inappropriately continued on these anti-seizure medications past that 7-day prophylaxis window. So patients getting stuck on therapy and extended on therapy that is not indicated or warranted. So just jumping back, where's the strongest evidence for seizure prophylaxis? Where did this all start? And I think we could go back to this Temkin study back in 1990. Now, this was an RCT that looked at phenytoin specifically for the prevention of PTS. Now, in this study, they actually looked at 404 patients, and to be included, you either had to have a cortical contusion visible on CT, a subdural, epidural, or intercerebral hematoma, a depressed skull fracture, penetrating head wound, seizure within 24 hours of that inciting injury, or a GCS of 10 or less. Now, this was a prospective randomized placebo-controlled trial that compared phenytoin, which was loaded at 20 mg per kg IV and adjusted based on serum levels, versus placebo. I think the important bit for our discussion today is really going to be looking at these results and maybe some of these raw rates of seizure. So they found early seizure rates in that 7-day period to be 3.6% in the phenytoin group versus 14.2% in the placebo group. So significantly lower rate of seizures in the phenytoin group. Now, just to note, and those who weren't treated on it with anything in this group, the rate of seizures was actually 14.2%. Now, this number will be important that we'll come back to kind of as we discuss the results of this meta-analysis here today. But there's going to be a lot of evidence that came after this Temkin trial that maybe didn't provide as strong of prospective evidence to support seizure prophylaxis in this group. But then jumping forward past maybe some of those retrospective studies, we do get the Brain Trauma Foundation guidelines for severe TBI. And essentially what these Brain Trauma Foundation guidelines are going to recommend, they're going to say that there's insufficient high quality evidence to support a level 1 recommendation for seizure prophylaxis. However, they do say that there is enough moderate quality evidence to support phenytoin and recommend it to decrease the incidence of early PTS. They say there's not enough evidence to recommend levetiracetam or Keppra over phenytoin, and that phenytoin and valproate are not recommended to prevent late PTS. Now, more recently, actually coming out last year, is going to be the NCS guidelines for seizure prophylaxis, again in moderate to severe TBI. So what we're looking at here is this meta-analysis looking at rates of early PTS within actually 14 days of this injury. Again, we're going to see the Temkin study pop back up here again, weighted at 12.7%. However, when we look at the results of these RCTs and non-RCTs together, they actually saw no significant difference here, again, with a risk ratio of 0.72 and that confidence interval crossing the 1. Now, just to note, there was significant heterogeneity across the studies with an I-squared of 68% and a p-value of 0.001. There was no heterogeneity between the randomized and non-randomized studies with an I-squared of 0 and p-value of 0.42. So based off of these results, NCS is actually saying we suggest that either prophylactic anti-seizure medications or no ASM be used in patients hospitalized with moderate to severe TBI. Now, they do note that this is a weak recommendation based on low quality of evidence. So this is just a graphic and a summary kind of to fast forward us to this point and briefly review some of the evidence that we've discussed already. So we said that when we're looking at maybe more of this moderate to severe TBI group, we saw the Temkin study had GCS of 10 or less and a lot of other qualifying imaging findings to include these patients, that it was overall positive to support seizure prophylaxis in this group. Now, we noted the Brain Trauma Foundation guidelines for severe TBI support the use of phenytoin in this group to prevent those early PTS events. And more recently, the NCS guidelines for moderate to severe TBI don't take a strong stance for or against, but say that it is overall reasonable. Now, where there is overall a gap we see over on this left side is there's not a lot of evidence that's been looking at mild TBI or mild to moderate TBI. So essentially what this study is aiming to do is fill this evidence gap, try and provide evidence for or against the use of seizure prophylaxis in this mild to moderate TBI. Which is what they state. They state that the purpose of this study is to determine the association between seizure prophylaxis and risk reduction for early post-traumatic seizures in mild and moderate TBI. Just briefly about the study design, this was a systematic review and meta-analysis that looked at studies that assess the effectiveness of seizure prophylaxis for early PTS. Now, all of these studies their quality was assessed using the Newcastle-Ottawa scale, or NOS scale, and they screened studies anywhere from January 1st, 1990, all the way through April 18th, 2023. Now, to be included in this meta-analysis, the study had to compare seizure prophylaxis in early PTS to a control group after a mild or moderate TBI event. They also wanted all these studies to report their data stratified by Glasgow Coma Scale, or GCS. Now, studies that were excluded if they had patients under the age of 18, had no comparator group without seizure prophylaxis, so no placebo, failed to report the rates of early PTS within 7 days. Maybe they picked an alternative cutoff, kind of like the NCS guidelines, where there was patients with pre-existing seizure disorders, or any study where the World Bank designated that country as a low or middle income country. So to just briefly go through the study enrollment, they screened a total of 896 records, of which 704 records were excluded right off the top during the title screening. That left them with 192 abstracts, of which 70 of these did not actually use any prophylactic anti-seizure medication, and 33 included severe TBI only. So they trimmed that down further to 64 full-text articles. Again, of these 64, 18 were excluded because they were narrative reviews or book chapters, 13 where they actually didn't report the GCS data, and again, 11 included severe TBI. So again, we are seeing a lot more evidence and studies looking at that severe or moderate to severe TBI population, which ultimately left us with 8 studies included for our primary outcome measure looking at mild and moderate TBI. Now we'll get to this in just a second, but you see that they're going to take another subgroup here at the very bottom of 5 studies specifically looking at mild TBI only, and this is going to serve as our secondary analysis. So just to go through the statistical analysis and how they actually perform this, they were looking at absolute risk reduction and 95% confidence intervals of seizure prophylaxis for early PTS for patients with mild and moderate TBIs. Now they went ahead and actually repeated the same process using absolute risk reduction for the mild TBI secondary analysis. Now, to account for any kind of heterogeneity amongst the studies, they did use a random effects model. And between study heterogeneity was tested with I-squared and a Cochrane-Q test. Now, this slide gives a little bit of information about all of the studies that are going to be included in the mild to moderate analysis, as well as those in the mild only analysis. Now, just to point out a couple key things that we can take note of, we do see that a majority of the available evidence included is going to be retrospective. There are a couple prospective studies here, but 6 out of the 8 are going to be retrospective. Now, what about our secondary or our mild TBI only sub-analysis? That's going to go ahead and look at these 5 studies. So again, we're looking at 4 retrospective studies and 1 prospective study for that mild TBI analysis. Now, the next question that I think will come up is, well, what agents were they using for seizure prophylaxis here? And we see in this column that a majority of the studies allowed them to really use any anti-seizure medication for prophylaxis. We do see 3 of them specifically used levetiracetam, but this could definitely affect how we interpret and apply the results here. And the last overall thing that I just wanted to note is if we look in the seizure prophylaxis and no seizure prophylaxis groups, overall, the percentage or rates of PTS, if you see the percentage in those far right columns, is relatively low. So across all of the studies, in prophylaxis or no prophylaxis groups, the rates of early PTS were below or equal to 5%. So this next slide just gives a little description of what is the Newcastle-Ottawa scale. So really what this is a Cochrane recognized quality checklist. They can go ahead and use it to assess the qualities of what are non-randomized observational studies then. And what this is going to do is they're going to take 8 items categorized into 3 different domains, which would be selection, comparability, and outcome. And the highest quality of studies when looking at these different domains, you can get up to 9 total points or stars. So while we did note that majority of these studies were retrospective, we see that the total points they're being given on this Newcastle-Ottawa scale do support them being of a higher quality evidence or good quality here as they note. Now, jumping more into the results, we can go ahead and look at our primary analysis, which is going to be seizure prophylaxis in this mild to moderate TBI group. So when it was all said and done, they found the absolute risk reduction to be 0.6% with a 95% confidence interval of 0.1 to 1.2% with a p-value of 0.02, indicating that rates of early PTS were significantly reduced with anti-seizure medications for this group. Now, that absolute risk reduction overall does look quite low, and when you calculate a number needed to treat, this actually comes out to 167. Now, they noted that the Cochrane-Q test generated a p-value of 0.13 here with an I-squared value of 4%, indicating no significant heterogeneity amongst the studies. We can actually see too as well in that funnel plot at the bottom, all of the studies except for that one outlier are going to fall within this 95% confidence interval. Now, what about our secondary analysis, looking specifically more directly at these mild TBI, this mild TBI group? Funny enough, we're going to get an identical absolute risk reduction again at 0.6% with a 95% confidence interval of 0.1 to 1.2 and a p-value of 0.04, indicating again that anti-seizure medications significantly reduce the rates of early PTS in this mild TBI subgroup. Again, the number needed to treat is going to come out to 167 in this group, and the Cochrane-Q test generates a p-value of 0.71 with an insignificant I-squared value, again indicating no significant heterogeneity between the studies. So there's a lot to digest, but ultimately what the authors conclude is they say that this study suggests that seizure prophylaxis may be effective for preventing early PTS or mild and moderate TBI. They do, however, note that the overall low prevalence of early PTS and low risk reduction against risks of anti-seizure medication should be weighed when deciding to start seizure prophylaxis. So jumping into a little bit of a critique, I think there are some strengths here that we can acknowledge. This was a meta-analysis that gives us the strongest compilation of the data, even if it all is retrospective in nature. And they took it a step further to validate the quality of these retrospective or non-randomized studies included with that Newcastle-Ottawa scale. So I think those definitely serve as strengths, but we do have some limitations to address. Again, these are primarily retrospective studies which are going to be included, which I think limits a bit of the applicability that we can have with this study. The authors do note that there is a potential for prescriber bias here. So even amongst all of the mild and moderate TBI patients, you may be biased to give prophylaxis to those who have the more severe injury, even amongst mild and moderate TBI. There's a lack of an overall clinically relevant outcome. We know that early PTS can be tied to worse outcomes, but it's not a directly clinically relevant outcome itself. And there's an overall lack of anti-seizure medication standardization. I think to make further conclusions from a study like this or an RCT, we would like to support the use of maybe one primary ASM. So when we think about some conclusions, ultimately, what are my concluding thoughts, my conclusions about this study? I do think it's as well designed as can be, but I think we have to acknowledge ultimately the limitations and what the results mean for applicability of the study. I think it primarily being that retrospective composition gives us pause a little bit in how we apply it, but even more importantly, I think the low rates of the early PTS here and the high number needed to treat shed more light really on my thoughts on this. So we noted that the rates in all of the retrospective studies were below 5%, and that is similar to the early PTS rates that we've been seeing without prophylaxis historically as well. So needing to treat 167 patients to prevent one early PTS in this population seems like quite a lot. So really, what are some future directions? Where can we take this from here? I think the small effect size really does limit the feasibility of any future studies. I think we would essentially need a really large RCT with over 10,000 patients to give any conclusive evidence for or against seizure prophylaxis in this population, which I think would be a tall task and I'm not sure would be able to be completed. So ultimately, how would this change practice, my practice, or we practice? I think I would not support the use of seizure prophylaxis in mild TBI. If there was a moderate TBI patient where there was some findings or maybe a penetrating head wound or some other criteria that would help us beat maybe like Temkin study inclusion, I would consider it. But yeah, I think that is my general concluding thoughts. I'd just like to thank Dr. Amar for helping me with this, precepting me on this presentation. And I would be happy to answer any questions, and thank you all for listening.
Anyone have any questions? Ah, there's a comment or question from Dr. Fontaine in the chat. For the PTS definition in these studies, was it all clinical seizures, electrographic seizures, or both?
That is a good point. I think it varied depending on most of them were going to be clinical. It wasn't pre-specified in the meta-analysis to be included in this study. So technically it could have been either one. I would have to go look a little bit closer. I know some of them were clinical at each one of those studies included.
It's also interesting to note that, I mean, it's estimated that we really only in the hospital see maybe 10% of the mild TBI patients as they present to the ED? Because most of them just stay at home with their headache or whatever. So in light of that, does that change how you view the study, knowing that it's probably the tip of the iceberg as far as the population goes?
Yeah, no, I think that's a great point. Again, amongst mild TBIs, that to me, that means you're probably seeing the worst of those mild TBIs. So if you include all of those patients, I think that probably drives down the rate of early PTS in this population even further. So we're saying if at the highest it's near 5%, if we include those patients who we aren't even accounting for, maybe that rate drops to an even lower percentage. So it's really weighing that probability. What's the probability of seizure there versus, well, are we going to throw someone on, phenytoin or Keppra and they get left on it, they leave the unit, and now all of a sudden they've been prescribed it outpatient. So I think that's really the risk benefit that you ultimately have to weigh. And I just think that there's a lot more benefit in withholding treatment in that group, in my opinion.
With that, I don't think I hear any more questions. We'll move on to our next speaker. Our next one will be Dr. Eric Kennison. He'll be talking about a study. He's a PGY2 critical care resident at Intermountain Healthcare.
Awesome. Thank you for that introduction. Hopefully you guys can see my slides. If not, somebody please say something and let me know. But excited to be here today. My name is Eric Kennison. I'm a PGY2 critical care resident at Intermountain Medical Center. Like she just mentioned, and today I'm excited to chat about intra-arterial tenecteplase following endovascular reperfusion for large vessel occlusion ischemic stroke. So we'll go ahead and jump right in if my computer will work. There we go. So I don't have any actual or potential conflicts of interest. These are just a handful of abbreviations that'll come up throughout the presentation today. I'll do my best to call them out whenever pertinent, but just to kind of make you familiar with these. And then here are some learning objectives for today's presentation. So first, really just want to review the epidemiology and pathophysiology of large vessel occlusions, evaluate existing recommendations and evidence for the treatment of these, both with endovascular thrombectomy as well as intra-arterial thrombolytics, and then ultimately apply the evidence that we'll look at to develop a treatment plan for using intra-arterial tenecteplase to treat an LVO. So first things first, just kind of looking at how common a large vessel occlusion is. Large vessel occlusions account for 24 to 38% of all acute ischemic strokes. And this definition or this percentage can vary depending on the definition of a large vessel occlusion and what vessels you're exactly using. And so some definitions even expound this out up to 46% of strokes. But generally speaking, it's about 1/3 of all acute ischemic strokes. And annually in the United States, we see about 80,000 cases per year of this. I think one thing that's important to note is the severity of these on the scheme of ischemic strokes. And so large vessel occlusions account for 60% of all post-stroke dependency and 95% of post-stroke mortality. So even though they're only accounting for about 1/3 of these strokes, they're responsible for the majority of disability following stroke as well as mortality. Just to do some really quick anatomy of like what we're talking about when it comes to large vessel occlusions. So this is kind of looking at different arteries that go to the brain, and these are really the ones that we're talking about when it comes to a large vessel occlusion. So mostly our internal carotid and our middle cerebral artery are what's reported in the studies that we're going to talk about today. But then also our anterior cerebral artery is included in some of these definitions as far as determining the epidemiology and frequency of patients having a large vessel occlusion. So just to briefly review the pathophysiology of how patients develop this, there's really four main etiologies that patients can have to develop their large vessel occlusion. First one being primary occlusion secondary to atherosclerosis, an extracranial plaque rupture, cardioembolic events such as AFib is really going to be the more common one there. And then, of course, any unknown causes or something that maybe doesn't fall into one of those previous three buckets. And so when patients do have one of these etiologies occur and develop a large vessel occlusion, they'll present commonly or with common symptoms of stroke. So maybe that like face numbness, slurred speech, poor balance, typical presentations of what we think of with an ischemic stroke. And then the diagnosis of this combines both really their clinical presentation, the timing of their symptoms, and then of course imaging to really confirm the presence of a large vessel occlusion. As far as the guidelines go for management of this, so these recommendations are pulled from the 2018 stroke management guidelines. So for patients presenting within 16 hours of a large vessel occlusion, mechanical thrombectomy is recommended, whereas compared to up to 16 to 24 hours, at that point, it's really only considered reasonable. So we're seeing a little bit of a softer recommendation as we get further out from their last known well. But in those first 16 hours, thrombectomy is what the recommendation is for treating a large vessel occlusion. And then just to highlight the main topic for today of intra-arterial thrombolytics, there actually aren't any comments addressing the use of these with mechanical thrombectomy. But of course, we're going to dive a little bit deeper into the literature today and come up with kind of our own thoughts and potential treatment plan. And so this is kind of our chronological course for the literature we're going to look at today. So first is going to be the 2016 Hermes meta-analysis, which was just comparing endovascular thrombectomy to standard medical therapy. Then we'll quickly look at the CHOICE randomized control trial, which was adjunctive intraarterial alteplase after thrombectomy. And then we'll spend the most of our time looking at the post-TK RCT, which was looking at intraarterial tenecteplase after thrombectomy. So there'll be pretty quick reviews of these first two trials, but this Hermes trial was a meta-analysis of 5 trials. You can see the abbreviation for what Hermes stands for there. And so really the background going into this trial is that there was 5 individual trials that showed benefit for interior occlusions, but this meta-analysis really wanted to go and combine these 5 trials together to see if that benefit was maybe still appreciated across the pooled populations or potentially any underrepresented groups. And so this included patients who had CT imaging to diagnose a large vessel occlusion, and the interventions were either a thrombectomy plus usual care or just usual care alone, which primarily included IV thrombolytics or alteplase in eligible patients. Then as far as the outcomes that they looked at in this trial, so their primary outcome was their modified Rankin score at 90 days. They looked at, for secondary outcome, early neurological recovery, which they defined as a reduction of 8 or more in their NIHSS score at 24 hours, or achieving modified Rankin score of 0 to 1 at 24 hours. And then safety was symptomatic intracranial hemorrhage. So in regards to the patients in this trial, baseline demographics were fairly balanced between the two groups. The only thing that I appreciated that was different was that in the thrombectomy or intervention group, 83% of patients received alteplase compared to 87% of patients in the control group, which was actually statistically significant difference with a p-value of 0.04. So just to point out that in that control group, we were seeing slightly more alteplase given compared to the thrombectomy group. And then the most common site of occlusion in this study was the middle cerebral artery, the M1 segment. So looking at the outcomes from the study, the main one I want to draw your attention to is the Rankin score of 0 to 2 at 90 days. And so seeing that 46% of patients were achieving that better score in the intervention group compared to just 26.5% of patients in the control group. And this came out to an odds ratio of 2.26, which was statistically significant for achieving an improved score on the modified Rankin scale with the thrombectomy compared to just usual care. We also saw significantly more patients achieve that early neurological recovery in the intervention group, and then fairly similar amounts of symptomatic ICH between the two groups. And so for the conclusions on this trial was that endovascular thrombectomy, in addition to standard medical care, improves the patient's odds of recovery, really both in the short term at 24 hours and long term at 90 days without any differences in harm realistically. So this supports the use of endovascular thrombectomy compared to just medical therapy alone. So now that we've established kind of the evidence for where endovascular thrombectomies plays a role, we'll turn now to more looking at adding on our intra-arterial agents to that. And so next we'll look at the CHOICE trial. And so the kind of motivation for this trial was that Hermes meta-analysis. And I didn't show just the modified Rankin scores of 0 to 1, but in the previous meta-analysis, that was only achieved in 27% of patients to be completely disability-free at 90 days with mechanical thrombectomy. So the CHOICE group set out to add on intra-arterial alteplase to see if that could improve outcomes, kind of with the thought process that following these large vessel occlusions, there's still maybe thrombi persisting in our microcirculation that can be treated by intra-arterial thrombolytics to help serve some benefit and improve really their long-term outcomes. So this was a multi-center randomized double-blind placebo-controlled trial with occlusions in the anterior, middle, or posterior cerebral arteries, thrombectomy within 24 hours of their last known well, and the patients had to be able to carry out usual activities prior to their stroke. Patients were randomized in a 1-to-1 ratio to either placebo or intra-arterial alteplase. And so the dosing that they used here was 0.225 milligrams per kilogram up to a max of 22.5. This was infused over 15 to 30 minutes. And then the outcomes that they looked at was achieving this modified Rankin score of 0 to 1 at 90 days. They looked at improved angiographic findings as their secondary outcome using the ETICI score, which ultimately just quantifies the extent of reperfusion achieved based on imaging. And then their safety, again, similar to the Hermes group, was symptomatic ICH. So in this trial, baseline characteristics were similar between the two groups. Similar most common site of occlusion being M2 segment. And then one thing I do want to point out is that 62 and 60% of patients, respectively, between the two groups were treated with IV alteplase prior to randomization. And so that wasn't a hard exclusion criteria in this trial. Seeing over half of patients still got IV thrombolytics prior to their thrombectomy and then their intra-arterial alteplase. So looking at their primary outcome, we did see a significant improvement in achieving those lower scores at 90 days with the alteplase group compared to the placebo group. And then really no significant differences in the angiographic findings. And then the symptomatic ICH was actually also not significantly different, even though those numbers do seem compelling with 0% in the alteplase group compared to 3.8% in the placebo group. One thing I do want to note is the group sizes in this trial. So 61 patients in the alteplase group compared to 52 in the placebo group. This trial didn't meet their power and they only achieved about 60% of their needed sample size. So this does introduce the possibility of a type 1 error here with the small sample size, and that this trial would be needed to be replicated on a larger scale to really confirm this. But the ultimate conclusion here is that in patients with a large vessel occlusion and successful reperfusion following thrombectomy, the use of intra-arterial alteplase did improve their likelihood of better neurological outcome at 90 days. And so now that we've looked at those two, we'll spend the rest of the time really in the meat and potatoes of today's journal club with the post-T&K trial. And so we'll go ahead and jump right into this. This was published actually just last month, so it's pretty recent data, hot off the press. It was published in the Journal of American Medical Association. And the background here really is that endovascular thrombectomy is the standard of care for large vessel occlusions. We looked at those previous studies showing in Hermes that endovascular thrombectomy improves outcomes, and then CHOICE potentially shows intra-arterial alteplase improves outcomes. So now we want to investigate if that same benefit is present with intra-arterial tenecteplase. The thought here being, as we know, that tenecteplase has a little bit more excuse me, fibrin specificity than alteplase and a longer half-life, hopefully would be able to replicate those outcomes. So this was a multi-center randomized open label trial conducted in 34 stroke centers in China. Patients were recruited from October of 2022 to March of 2024. As far as the patients that they included, Patients had to be 18 years or older, an NIHSS score of 25 or less, and then occlusion of their ICA, first segment of their MCA or second segment of their MCA. Some key exclusion criteria that I do just want to point out is that patients couldn't be included if they had pre-stroke disability, which was defined as a modified Rankin score of 2 to 6. And then they also excluded patients treated with IV thrombolytics before the thrombectomy. And so that's a key difference that we need to consider in this trial compared to the CHOICE trial, is that patients here did not receive IV thrombolytics prior to their thrombectomy and then ultimately their intra-arterial thrombolytics. Patients were randomized in a 1-to-1 fashion to either receive tenecteplase or be in the control group, and tenecteplase was given at 0.0625 milligrams per kilogram up to a max of 6.25 milligrams, infused over 10 to 15 minutes through distal access catheter positioned proximal to the occluded artery. So the outcomes that they looked at in this trial is the primary being freedom from disability at 90 days, which is defined as a modified Rankin score of 0 to 1. And then some key secondary outcomes they looked at was a functional independence. So just expanding that score out to 2, their NIHSS changed from baseline. And then this EQ score at 90 days. This is a scoring system that I ultimately wasn't familiar with, but basically it scores patients on 5 different categories, that being mobility, ability to perform self-care, their usual daily activities, their pain and discomfort, and then the last one being anxiety and depression, with lower scores indicating a worse quality of life. Just to orient those who might not be as familiar to this, as it's not a super common outcome used that at least I've seen. And then some safety outcomes they looked at was death due to any cause within 90 days and symptomatic ICH. So just to quickly review their stats, what I really want to emphasize here is just the sample size that they calculated to meet power. And so they needed 236 patients per group to achieve 83% power. And so they targeted an enrollment of 249 patients per group, accounting for a 5% attrition rate. And so looking at the enrollment that they had, really kind of bringing your attention to the bottom, is that they had 269 patients included in the tenecteplase group, and then 270 into the control group. They did lose 1 to follow up, but overall they did end up meeting power for this study. And ultimately the most common criteria for exclusion was just the site of their large vessel occlusion, being the reason that the patient couldn't be included in this study. So just some key baseline characteristics. Overall, demographics were balanced between the 2 groups, but just so you can see kind of the breakdown, it was a mostly male population. Majority of patients didn't have any disability prior to their stroke. Median NIHSS score of 15, and then the breakdown of their occlusion sites are there as well. And then one thing I don't have on here is their median time to tenecteplase was around 8 hours for both groups. But overall balance between the 2, which is important and something that that we like to see. So looking at their primary and secondary outcomes, really what I want to bring your attention to is their modified Rankin scores of 0 to 1 and 0 to 2 at 90 days. There wasn't any statistically significant differences between the 2 groups here, evidenced by those p-values, but we can kind of see a little bit of a shift favoring the tenecteplase group. So theoretically, if we were to calculate a number needed to treat, if it were significant, would be 5, or excuse me, 20 for patients in the tenecteplase group to achieve that Rankin score of 0 to 1 at 90 days. But again, it wasn't a statistically significant difference, though it is something where you could definitely argue this is a clinically significant finding. And then just kind of looking at their changes in scores, no significant differences there. And then there was a subgroup analysis performed on the primary outcome as well. None of the findings there were statistically significant either. The only one that was fairly close was in patients who presented with an NIHSS score of greater than 15. So next we'll look at safety outcomes. The main one I want to bring your attention to here is mortality at 90 days. There wasn't any significant difference there, but there was a significant difference in patients with radiologic evidence of intracranial hemorrhage within 48 hours. Not necessarily symptomatic, but in patients just getting their standard imaging performed, there was a significant difference seen here, showing more radiologic ICH in patients who were in the tenecteplase group, which I just think is something to note. But overall, no differences in mortality or symptomatic bleeds. So just kind of looking at the trial altogether, some strengths and limitations that I appreciated. So I think the first strength is that it was a randomized controlled trial that did meet power with evenly distributed patient groups, and is the largest one to provide evidence on adjunct tenecteplase following a mechanical thrombectomy. Some limitations, it was open label. It did exclude patients who received IV thrombolytics. And so that's something that I would have loved to see, especially kind of mimicking the setup of the CHOICE trial to see if the outcomes that the CHOICE trial found could be similar here in the post-TNK trial. And then it was also only conducted in Asian patients. So just being able to extrapolate that to other demographics can kind of present a limitation there. It might be something to consider in future trials that would try to replicate these results. Is expanding the patient population. So the conclusions that the authors had was that adjunct intra-arterial tenecteplase following thrombectomy doesn't improve a patient's risk from disability. Although despite a lack of statistical significance, they do believe that there is a clinical significance that can be appreciated. And so that can't necessarily be ruled out, even though those p-values weren't necessarily significant. And then just summing up with the safety events, that there was more radiographic evidence of ICH, but not an increased risk of mortality or symptomatic bleeds. For my own personal conclusions, so for me, intra-arterial tenecteplase following thrombectomy does not improve a patient's risk from being disability-free at 90 days, and it does increase the risk of radiographic bleed, though not symptomatic, kind of like I've mentioned a couple times. And so for me, given the lack of benefit demonstrated at 90 days, I would not at the current time recommend just like blanket intra-arterial tenecteplase for the treatment of all large vessel occlusions following thrombectomy. I think when trying to define the patient that would be appropriate to give this to, like I mentioned, they did a subgroup analysis, and though none of that was statistically significant, patients who had higher stroke scores at presentation did have an odds ratio of improved outcomes of 1.38, and their confidence interval was 0.99 to 1.92. So we're right on that cusp of that being statistically significant as well. And so I think for me, the patient that I would feel compelled to recommend this in, or at least have the discussion, is patients presenting kind of with those more severe stroke symptoms on presentation, who might have more of that microcirculation thrombi persisting and could benefit from this. But for patients with lower disabilities at baseline and lower stroke scores, it doesn't seem potentially like the risk could be worth the benefit here, as far as like regaining function, although increasing risk for a bleed, at least on imaging. But those are my conclusions. And so when we wrap up here, I'd be happy to hear if anybody else has any different opinions. And then just some next steps and considerations, I think, in the realm of intra-arterial thrombolytics. So kind of mentioned earlier, but I think the next step for me would be trying to repeat post-TNK without excluding patients who received IV thrombolytics. I think that was one of the biggest differences between post-TNK and CHOICE, was that exclusion criteria. And then, of course, the population sizes were just a little different, in that post-TNK achieved their needed sample size to meet power compared to CHOICE, which didn't. Maybe that's why we didn't see a difference in post-TNK, and maybe that really does kind of reintroduce the idea of a type 1 error with the CHOICE trial. And then just some other studies that are either been completed or kind of expected to come out soon. So there's the post-UK trial, which was a similar trial design to post-TNK, just performed with urokinase. They also did not find a difference in their Rankin scores at 90 days mortality or their symptomatic or radiographic bleeds. And then a couple other trials is Techno and CHOICE 2. And so Techno is a trial that's I think going to be, if I understood all of their protocols correctly, post-TNK with patients who did get IV thrombolytics. I did not see that as a hard exclusion criteria in their criteria, but they are actively recruiting, hoping to enroll around 150 patients. What I saw their targeted population is, I think anticipating being done with enrollment later this year in October is what I saw. And then CHOICE 2 is going to try to validate if intra-arterial alteplase is effective as an add-on to mechanical thrombectomy. And so they're targeting an enrollment of 440 patients in that trial. And I believe they're expected to be done enrolling in May of this year. So a couple of studies that hopefully we'll see here kind of in the near future that can really provide extra evidence on this exciting topic in regards to stroke management. So just some key takeaways to wrap up today. So large vessel occlusions account for almost a third of all acute ischemic strokes, with thrombectomy being the standard of care. And at the current moment, there's no comments in the guidelines on the use of intraarterial thrombolytics in addition to thrombectomy. We looked at the CHOICE trial, which did show intraarterial alteplase improved neurologic recovery, but as we mentioned, they allowed IV thrombolytics prior to thrombectomy, and they also had a smaller population size and did not meet power. And then post T and K, which is the one we looked at for most of our time today, did not statistically improve the risk of being disability free at 90 days, although that doesn't exclude a clinical significance with a potential number needed to treat there of 20, and then did show increased risk for radiographic evidence of an intracranial bleed. And so I think the big thing that we'll be looking forward to kind of really hammer home some of this data will be those upcoming trials with Techno and Choice 2 to see what those show and if that can change practice. So here are my references for today. Thank you all for your time and attention. And with that, I'd be happy to answer any questions that anybody has. And if you can't think of them now but want to email me later, there's their email to contact me.
I don't see any questions in the chat, Eric, but I guess since you harped on it a couple times, can you talk us through the significance of clinical significance when you're not sure if that difference is actually true?
Yeah, I mean, so I think the thing to always think about when looking at studies is, statistical significance is an all or nothing kind of achievement, but that doesn't rule out that the numbers could still be persuading to use as a treatment. So I like extrapolating from their subgroup analysis of patients with a stroke score of greater than 15, they didn't achieve statistical significance by probably one patient based off of that confidence interval. And so for me, like that's why I think there's a clinical significance there, and that those patients who have those higher stroke scores and more disability on presentation could benefit from this. And same thing, even looking at the primary outcome, I think the numbers weren't as compelling as the subgroup analysis to make it like a blanket recommendation for me. But I think that would just be my own personal opinion. I think you could definitely be convinced that there is clinical significance overall to want to give intraarterial tenecteplase place to all large vessel occlusions. I don't know if that answers the question, but
Well,
yes.
kind of. I guess it does. Is the increased risk of intracranial hemorrhage also clinically significant?
Yeah, I would say so. And looking at their radiographic evidence, that was also statistically significant. So I think the symptomatic bleeds, I wouldn't say was clinically significant, but I think considering like ultimately the hemorrhagic conversions they would be having from the radiographic evidence would also be clinically significant. So really just ultimately balancing out that risk benefit ratio.
It's funny they kind of commented on one but not the other,
Right.
but you can imagine why. Abby Hickman's got a question in the chat. Was time to antiplatelet or anticoagulation addressed in this study?
I don't remember. I'm assuming you mean like if they were on anything prior, or do you mean after the thrombectomy and receipt of intraarterial tenecteplase? After. I don't remember seeing anything about at what point they were started, but I can definitely double check that and get back to you.
Well, I'm not seeing any other questions. Abby Hickman did have another comment, curious if that would have affected the functional outcome scores at all. But I wanted to thank our presenters today. I also wanted to thank our facilitators and our coordinators for this. Thank you guys all for coming and showing up today, and I really appreciate it. Have a good rest of your guys' day.